This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tesha Monteith with the Neurology podcast. I'm back with the November headache series. This session is focused on both high and low CSF pressure disorders. With me to discuss is Kathleen Digre, Professor of Neurology and Ophthalmology at the University of Utah, as well as Deborah Friedman, a neurologist in Dallas, Texas. Both Kathleen and Deborah have been instrumental in helping us better understand the diagnosis and management of both SIH and IIH. Thank you, ladies, for coming on to the podcast.
Well, I'm delighted to be asked, and of course, I couldn't be happier than to be with my colleague and friend, Deborah Friedman.
She took the words right out of my mouth.
That's what I mean. You're the dynamic duo of CSF pressure disorders. What's new in the diagnosis of idiopathic intracranial hypertension?
Well, I'll be happy to start out giving you what's not new, just because I think we need to make sure that we all do a history looking for risk factors for raised intracranial pressure. Sometimes medications can cause it, like tetracycline, minocycline. Sometimes sleep apnea, obesity, and its comorbidities are very rampant. And for every patient, we have to get an MR with gadolinium. And in some cases, if it's atypical, we have to get a venogram, a MR venogram. We have to do a lumbar puncture to rule out a secondary cause, even though some of our colleagues are thinking we don't have to do that, but we really do. And we have to get visual fields. And for neurologists, this is really a challenge because most neurologists don't have visual field in their office. And sometimes it's nice to get a optical coherence tomogram on some of these patients too. So that's not what's new, but there's a lot of things that are new in some of the treatments for weight loss, which I know we're going to be getting into, and some of the treatments for reducing the intracranial pressure, like stenting, is another new thing.
Deborah, I want to ask you about IIH without papilledema, because I know you've been involved in some of that writing.
You know, on your podcast, you have two of the three people who wrote the diagnostic criteria for IIH that were published in Neurology in 2013. And those criteria, according to us anyway, still stand. We talked about whether we should revise them again because it's been 10 years. But really, as Kathleen notes, that not that much has changed. So when the two of us and then Grant Liu, who was the third co-author, when we wrote the criteria, we purposely tried to make it difficult for people to make the diagnosis of IIH without papilledema because we thought that it was being overdiagnosed, particularly amongst headache specialists. Kathleen and her team at the University of Utah did a study where they looked at their neuro-ophthalmology practice and found that only 5% of their IIH patients did not have papilledema. And a lot of those patients had non-organic functional visual loss. A lot of them just had intractable headaches. So we stand by our diagnostic criteria. And in order to make a diagnosis of IIH without papilledema, there are two ways to do it. Either you can make a definite diagnosis if you meet all the other criteria, meaning the MRI, the lumbar puncture opening pressure, the normal CSF pressure. If the patient also has either a unilateral or bilateral sixth nerve palsy. But in practice, that really doesn't happen very often because most people get papilledema before they get a cranial nerve palsy. So you can make a suggested diagnosis, but not a definite diagnosis, if the patient meets criteria based on imaging findings. So there are 4 cardinal imaging findings, and they need 3 of them, and those are empty sella or pituitary flattening, expansion of the perioptic subarachnoid space, flattening of the posterior globe, or transverse sinus stenosis. And transverse sinus stenosis actually turns out to be a pretty good predictor, but you have to keep in mind that this is a diagnosis that is a package deal. Like one sign in particular is not going to make the diagnosis. And an MRI that shows some abnormal findings in the absence of anything else does not make the diagnosis. So I would be really wary and leery of making a diagnosis of IIH without papilledema. I just don't think it's all that common. And I still think it's being overdiagnosed.
And I would agree.
I think part of that is we get MRIs very often. And I know that I've at least had some cases of patients with intractable headache, migraine. They get a lumbar puncture and it's marginally elevated or normal, but they have a couple of those findings. And what do we do with those cases?
Well, the group at Emory has done a lot of investigation into this. And their bottom line is send the person to an ophthalmologist. Like, we're getting all these consults for people who are being referred because they have an abnormal MRI of the brain. And maybe somebody reads out transverse venous sinus stenosis when it's really an atretic venous sinus that they were born with. And so, again, you have to follow all of the diagnostic criteria, or you run the risk of diagnosing the patient with something they didn't have. And the problem is then they undergo all these procedures, and sometimes surgical procedures or interventional procedures that they didn't ever need to have. And those procedures are not without potential risk.
So let's talk about some of those procedures and at least potential risk factors that might lead to negative outcomes that would warrant a procedure.
I think it's been very clear that when people present with severe papilledema and visual field loss, we sometimes call this fulminant idiopathic intracranial hypertension. These are people at very high risk. And this is really an emergency where you have to make the diagnosis quickly. We have established a program where we put them in a lumbar drain situation and get the pressure off. And then we make a decision about what kind of surgical procedure we need to do while we treat them with high doses of acetazolamide, hoping that that will control it. And there are many other studies out there that have said besides severe papilledema and fulminant idiopathic intracranial hypertension, male patients, maybe because they come in late, African American, are more likely to have severe visual loss. If people have visual field loss at the onset, that's another group of high-risk individuals. The other group that I find really difficult to take care of are people who are unreliable for follow-up. So let's say you make the diagnosis, you get a field, you know what they've got, you put them on acetazolamide, and they don't come for follow-up. So those people are another group that I really worry about as well. Deborah, what do you think? Do you think there are other people that we should be worried about?
I would also add people that present with visual acuity loss at presentation. And a lot of neurologists no longer feel all that comfortable doing a fundus exam, and you can't do an automated visual field at the bedside, but you certainly can take somebody's visual acuity, right, using a near card. So people who come in that already have loss of central vision at the time of their presentation have a much higher risk of experiencing long-term visual loss.
So you spoke about papilledema and some of the progressive findings. What about ultrasound? Is there a role for ultrasound in predicting those that might have a more negative course?
In my practice, no. I love ultrasound for lots of reasons, like looking for buried drusen, that somebody might have buried drusen. You can have buried drusen and swelling, and that might be another risk factor for visual loss. And a lot of people do what's called the 30-degree test to see if they think the pressure is elevated, but I haven't really used ultrasound as a predictive thing for visual loss.
So let's move on and talk about weight loss. I mean, when I was training, I was kind of like, weight loss is the gold standard. I know it's far more complicated than that. And there's a heterogeneous disorder. We have to preserve vision and all those things. But in many of our patients, we do have to talk about weight loss. And I think neurologists don't always do a great job of educating, and not just neurologists, but maybe clinicians in general. We don't get a lot of training in medical school about nutrition and how to lose weight. So let's talk about some of these newer drugs that are on the market. Everyone's talking about glucagon-like peptide receptor agonists. What are your thoughts on that?
So I've been looking into this because I've got a lot of patients that are coming to me wanting to be on this drug. And then what do we know about these drugs for idiopathic intracranial hypertension? Well, first, these drugs have been used for diabetes for several years. and have been very good at helping people lose weight when they've got adult onset diabetes and for diabetes prevention and weight loss. There are only 2 trials that I'm aware of looking at the GLP-1 receptor agonists. The one was done by the Birmingham group. Mitchell was the primary author. Alex Sinclair, I think, was a senior author, published in Brain of 2023. And this was a very good trial where they enrolled 16 patients and they randomized 15 of them either to exenatide or placebo. It was a prospective trial, and they all had very in-depth telemetric monitoring of their intracranial pressure at 2.5 hours, 24 hours, and 12 weeks. And the exenatide did lower the pressure at each of those time points. What was interesting to me, however, was the number of days improved, but the severity did not improve. So we need a lot more information on this drug in that prospective trial. Then another report came out in the Journal of Headache Pain, where they took 39 patients with IIH and treated 13 with a receptor agonist and 26 to the usual care. And they achieved 12% weight loss with those in a GLP-1 group versus 2.8% in the placebo group. But the visual outcome at 6 months, no difference. Headache improved in the GLP-1 group, 76% improved versus 40% on placebo. And there were some adverse events, mainly nausea and some gastroparesis. I think this is a story to be continued, because it is a remarkable drug for weight loss, but it does have serious side effects. Some of the big reviews that have looked at the very serious side effects, things like pancreatitis, gastric stasis, and a lot of nausea. So I think the jury's not out on this, but we're going to see more of it. The biggest problem I've got in my patients is that they get prescribed this and then they can't get it because it's not available. It's just, there's a shortage of the drug.
So, Deborah, have you sent patients for bariatric surgery? How often have you done that? And what does the literature say?
I have sent some patients for bariatric surgery. The number is not huge. And sometimes it gets approved and sometimes it doesn't get approved. Unfortunately, a lot of times the third-party payer has more to say about what the patient needs than we do. But there was also a trial that the Birmingham group did called the IIH weight trial, where they randomized people to either receive bariatric surgery or just kind of standard of care dietary measures. Not surprisingly, the people who got bariatric surgery lost a lot more weight, right? That was their primary outcome, was weight loss. And I don't think any of us were too surprised to see that they lost weight. The outcomes that I would say, as neuro-ophthalmologists anyway, that we are concerned with, such as their visual parameters, they were all secondary outcomes. Headache was a secondary outcome. But in general, people seem to get better. There are studies from the older literature on bariatric surgery looking at people who had migraine, showing that weight loss even helps migraine. So I'm not sure that the improvement in headache is entirely due to lowering intracranial pressure in these people, although the ultimate result was that it did lower intracranial pressure, but it may have a totally different mechanism that I'm not really sure about.
Kathleen, what are your thoughts on that?
I would like to just add there is a systematic review that is in a preprint format in the journal Neurology that is going to be coming out, where they really did a wonderful systematic review looking at 17 studies of bariatric surgery, several studies of lifestyle interventions and diet interventions, and they really clearly showed that bariatric surgery does give you the most weight loss, and it does give you probably the most decrease in intracranial pressure, although it was pretty close with if people can really lose the weight in the cases like the IIHTT, where they did a lumbar puncture after the weight loss intervention, they could show that the pressure did come down. And they even did look at headaches. So I would urge our listeners to look at the Green Journal when this study comes out. And it's a very interesting study. And it really kind of makes an argument for weight loss surgery, especially gastric bypass versus some of the other less invasive surgeries. But it's one of these things where we can make these recommendations for some of our patients that really can't lose the weight, But then again, sometimes the insurance companies won't approve it. I've had so many cases where I've tried to get that approved. I've given them articles, I've written letters, and you just can't get it done.
I would add that a lot of these people have been struggling with their weight all their life. And just telling somebody to go lose weight, it's not easy. They've tried a lot of different ways to try to lose weight and have been unsuccessful. So to have options like, the new medications that we have, the GLP-1 receptor agonists and bariatric surgery, I think would be a real benefit to many of these people who are kind of at their wits' end, and they've tried everything they know how to do. And a lot of these patients also have polycystic ovary syndrome, which makes it even harder to lose weight. So I think, a little compassion is probably due there as well.
And also, Kathleen, you were speaking about some of the surgical interventions like venous sinus stenting. Why don't you talk a little bit about that, any recent clinical trials, and where we are as a field in being a little bit more accepting of these procedures?
We use surgical procedures for visual loss, not for headache, not for anything else, but we got to do them for visual loss. We can't be just doing procedures on people. And the procedures we have for visual loss with IIH, we have optic nerve sheath fenestration, which does help with the papilledema, sometimes doesn't help with the headache. We have shunting, which sometimes gets the pressure off and may help for a while, but these shunts tend to fail. So one of the new kids on the block that's been around for a few years and has been looked at is called venous sinus stenting. Now, this procedure is an invasive procedure, and you have to put a stent inside of a vein to try to get past a stenotic area or maybe an arachnoid granulation that's causing a stenotic area. And they do really drop the pressure. And there are lots of small studies. There's some bigger studies. There's a wonderful systematic review that was published in the Journal of Neuro-Ophthalmology by one of our colleagues, Dr. Dinkin from New York. And so pressure definitely comes down with the stents and symptoms get better, pulsatile tinnitus gets better, and the papilledema does get better, and headaches do improve, but that was the least thing that improved. In fact, some of the people get really bad headaches at the time of stenting because remember that the trigeminal system innervates these veins, and so they can get pretty bad headaches. And there are complications. The stents can thrombose. You can get a subdural hematoma. You can get cerebral edema. The stent can migrate, and there's even been death. So I think it really has to be a well-chosen person. I personally have done it on very few people, usually with very fixed stenoses where I've tried other things and it hasn't worked. And I can't get the papilledema down due to the other procedures. I've sometimes resorted to the stenting. I think we have to be really careful about this procedure.
Deborah, what's your experience?
Well, Dr. Dinkin's paper, he also points out that 9% of people had recurrence down the line, and they had to go have a surgical procedure. So, it's not perfect, but it, in general, I think is a good option for many people. The metric that seems to predict improvement the best is the magnitude of the gradient across the stenosis. So when the interventional radiologist is trying to decide whether or not this person is a good candidate, they do manometry and they measure the venous pressure on one side of the stenosis, and then they measure the venous pressure on the distal end of the stenosis. And the difference between the two is called the gradient. And the higher the gradient, the more likely it is the patient will have a good result. And the magic number is around 20, although they will stent for numbers that are much less than that. A lot of places, their cutoff is about 8 millimeters of mercury. The higher the gradient is, the more likely it is the patient will benefit.
Okay, so we have a patient diagnosed with IIH, had the appropriate testing, and lost weight, listened to the podcast, decided to lose some weight, got put on some diuretics, vision has improved, papilledema is resolved, but I'm still having this darn daily headache. Dr. Friedman, Dr. Digre, yeah, sure, my vision is better, yeah, but I'm with this headache and I can't function. Fix me.
Well, this happens in about 2/3 of people who have IIH. They have continuous headaches, probably as a result of central sensitization from the time that their intracranial pressure was elevated. And what we know is that acetazolamide is not a great headache drug. it's just as good treating headaches as placebo, which is what we found in the IIH treatment trial. And yes, people's headaches got better, but no better with acetazolamide than placebo. The basic strategy is to treat their headache, and we treat it by their phenotype. And in the IIH treatment trial, the most common phenotypes were either migraine or probable migraine, or less commonly, tension type headache or probable tension type headache. So we would treat them like they sound. I like to use topiramate in patients who have IIH. You get the benefit of reduction of CSF pressure, as well as maybe some weight loss, as well as headache improvement, or you could use zonisamide for patients that don't tolerate it. There was actually a really cool study that was just published. It was done in rats, so I won't belabor the point. But basically what they found in rats was that the combination of acetazolamide and topiramate worked better than either one of those alone. So there at least is some scientific rationale for combining them. They work by different mechanisms because topiramate had an effect on some of the genes expressed by the choroid plexus, whereas acetazolamide didn't. So you could try combination therapy. But other than that, the field is wide open. We can use whatever we would normally use for anybody else who has an intractable headache, including botulinum toxin A, including the CGRP antagonists, including probably any of the headache preventatives and acute medications, except we want to try to stay away from the ones that cause weight gain. So valproate is probably not the greatest choice, for example.
I would just echo that I do treat a lot of people with the combination of acetazolamide and topiramate, and I do find that is very helpful. But sometimes that isn't enough. And we have used the CGRP monoclonal antibodies, and there have been some small little studies that have shown that maybe patients are better with that. So I think it's worth trying if they've got really bad migraine and it's not responding to medication normally. And the botulinum toxin we have tried too, with some success in some people.
So it sounds like topiramate is a favorite because of the weight loss potential, and combination is maybe ideal. But both of these drugs have sometimes tolerability issues, both when used alone or used in combination. So are there alternatives to these two diuretics that you use in clinical practice?
If they can't tolerate acetazolamide, I've used methazolamide, a close cousin to acetazolamide. Sometimes I've had to use furosemide, which I don't think works that well. Chlorothalidone has been reported to be helpful in some. So yes, we do use other diuretics on occasion. As far as an alternative to topiramate, sometimes I've used zonisamide with fewer side effects, but I don't think it works quite as well as topiramate.
But again, for the headache, it's not so much about lowering intracranial pressure at that point, right? Usually these patients, their papilledema has gone away and everything else looks good, but they have ongoing headache. So we would use headache medications. The other thing we found out in the IIH treatment trial was that the prevalence of self-reported migraine prior to developing IIH was a little over 40%, which is more than twice you would expect in the general population, right? For women, it's about 18 to 20% have migraine. So they may be primed to have ongoing headache when all is said and done.
Where is the field opening pressures, right? Because we're all different. We're built differently, some taller, some shorter. And these are averages, estimates. So what are the thoughts on opening pressure?
Don't worship the pressure alone. As Deborah said at the beginning, this is a package deal. You have to have the symptoms. You have to have the signs. You've got to have the imaging. Do you know what I mean? You've got to have all this stuff. So if you hang your hat on the pressure alone, you are going to be mistaken frequently.
Great. So I think that was a great conversation about high pressure headache, IIH, but let's spend a little bit of time talking about low pressure headache syndromes. We're still not maybe diagnosing this as fast as we should, right, when they're spontaneous cases. So how can we improve the diagnostic yield?
Well, first, you really have to have a very high index of suspicion. And that really comes from taking a very detailed history. So the classic person who has what we call spontaneous intracranial hypotension, or SIH, has orthostatic headache. And about maybe 90+% of people who have a SIH have orthostatic headache at some point. But not everybody does. Some people have headaches that are not really either present or severe when they first wake up in the morning before they get out of bed. But as the day goes on, they start to develop a headache that progressively worsens over time. We also like to hear about the headache improving in recumbence. And not just because they lie down and go to sleep and take medicine, but actually just lying down helps the headache. But there are all these other symptoms that patients can have. They frequently will have eighth nerve manifestations, such as dizziness, not really lightheaded, but vertigo, imbalance, muffled hearing, various tinnitus, which is usually not pulsatile tinnitus like IIH, but sometimes it is. They're just myriad symptoms that people can get. And so it takes a logical approach to this. And sometimes maybe even have a list of questions that you want to either ask people or send them home with so they think about it. But in people who show up for evaluation that have what you might think of as a new daily persistent headache or chronic migraine that just kind of never goes away, and whatever you try, it doesn't work, and they're not an obese female of childbearing age, where you think about high pressure, or people that have headaches that follow what would be considered pretty trivial trauma. They may have been in a car accident, they may have had a whiplash injury, they may have fallen and bumped their head, or been in a sports injury, or done a little too many burpees, or even people who have a history of dural puncture, and it can be a remote history. So as neurologists, we're doing lumbar punctures or sending our patients for lumbar punctures. But keep in mind that despite what they used to teach us many, many years ago, a spinal headache doesn't always go away in 2 or 3 weeks. There are some people that have spinal headaches that are persistent, or there are people that have a history of having a lumbar puncture or epidural anesthesia who will down the road develop these new headaches. And it turns out that they're leaking. So it's just something that we really have to have in the top of our mind and be detectives and be really suspicious of so that we can go to the next step.
Yeah, I had a good case of that. I had a patient that had spinal anesthesia for delivery and, recovered and didn't really have headache. It was more like, maybe she had 1 or 2 per month. That sounded like migraine attacks, and even there was aura. But she had some kind of subtle dizziness. And she recalled it, being even hard to lift her baby. And one day she was moving a couch and the leak happened in full force. And we saw the leak, we patched her up. But going back, and because she was in her health system, which is helpful, I was able to see those prior visits with my colleague. And these were very subtle, very not like the severe leak headache. So maybe there was some very low grade leak or low pressure that was happening all along.
I've seen this as well, especially after delivery and even diplopia, because they get a little subtle bilateral 6th nerve palsy and it comes on after delivery. And you get the scan and you may not see all the findings. You might not see the nice smooth dural enhancement and all that, but the pituitary may be a little bit more full than you'd like to see, and that tonsillar ectopia may be present as well.
I'll say that we would be doing the health systems a great favor, as well as the patients a great favor, to stop using cutting needles when we do these procedures. There are needles that have a much lower risk of producing a CSF leak. And unfortunately, our spinal trays come with these quinky cutting needles that they just do a lot of damage.
So why don't we talk about a diagnostic testing to better diagnose a CSF leak?
I started to say that you definitely need an MR with gadolinium to look for that dural enhancement, which is so characteristic. It's really smooth. It doesn't have lumps and bumps in it, like other types of meningeal enhancement. And then all the characteristic findings on a sagittal view, looking at the pituitary, looking at the distance of the tonsillar descent, and just looking at the configuration of the whole posterior fossa. And many people recommend getting a heavy weighted T2 imaging of the entire spine. And you really have to work with your neuroradiologist. If you suspect this in your patients, you really have to work with a neuroradiologist, just because they need to know what you're looking for and what you want to be finding. And that's what we do. We have kind of a protocol in our center that when we suspect this, we kind of write that's what we suspect. And then they're much more in tune with looking for all the findings.
The nice thing about the heavily T2 weighted MR, which is also with fat saturation, is that, first of all, it's totally non-invasive. So it often will give you a clue that there is a CSF leak, particularly if it's from a dural tear. It has its limitations, though, so it is not as good as localizing a leak, and it also is not as good for detecting a CSF venous fistula, which is the cause of leaks in about 25% of people who have SIH. So other tests that can be done include a CT myelogram, and this is done differently than when looking for spine disease or low back pain. It's done with the patient prone on the table, not supine on the table. And it can also be done with decubitus views. And then there's another technique that is called digital subtraction myelography, which is a kind of a much bigger deal. You need to go to a specialized center for it. But again, if you get the patient imaged with digital subtraction myelography in the lateral decubitus positions, then the likelihood of picking up one of these fistulas goes way up. But I have to tell you that a lot of times these leaks are very, very hard to find. We do multiple procedures on people, and we have so much trouble finding the source of the leak. And a lot of times we'll just kind of treat them empirically if we're highly suspicious, especially if their brain MRI shows signs of low pressure. So we may just go ahead and do a lumbar blood patch or a multi-level non-targeted blood patch to see if the patient gets better. Once you image the spine, then you can do targeted blood patches, but it helps to have something to target, right? And often it's really hard to find something to target. The other thing that we generally don't do is a lumbar puncture. So even though we call this spontaneous intracranial hypotension, only about maybe a third of people who have SIH have a low pressure, which is 60 milliliters of water or less. So we generally do not stick needles in people's backs to measure their pressure because it can actually make them worse. And if they go for myelography, then the neuroradiologists or the interventional radiologists can measure their opening pressure at that time if we need more confirmatory data.
What I'm hearing is it's not always easy to find the etiology. There's some more rare cases like the venous fistula and, of course, malformations. There are a number of etiologies. Are there any new management approaches to treating some of these etiologies and diagnosing too, if you want to mention that?
I think the digital subtraction myelography is really kind of the new kid on the block, but it's not done everywhere. And I think this is a team sport. This means you have to work with neuroradiology. You might have to work with neurosurgery if they understand how these leaks occur, because I've sometimes had to have the neurosurgeon go in and close a leak. So I really feel like it's a team sport. And the more you can work together on somebody, the better chance of having some kind of success.
The other thing I would add is that the real challenge is when you have a high clinical suspicion, but the MRI of the brain is normal and it doesn't show any signs of intracranial hypotension. And this happens in probably 15 to 20% of people. So it's not a trivial proportion, right? And then you're in the kind of additionally difficult situation of trying to convince your interventional radiologist or your neuroradiologist to start doing invasive procedures on someone when they have a normal brain MRI. It's not just frustrating for us, it's super frustrating for the patient. And so that's why we would often just go ahead and proceed with doing a non-targeted blood patch at that point. If the patient gets better, then you have a little more evidence behind you that we should look harder.
So we talk about uncommonly diagnosed disorders or lesser known disorders, but these aren't rare disorders. We do see them. Neurologists come across these patients all the time in both academic settings and private practice settings. And from what I'm hearing is that you want to collaborate with people that have experience as much as possible. But let's talk about what an ideal multidisciplinary approach would be. You mentioned working with some neurosurgeons and radiologists. Maybe we'll have Deborah give us high and we'll have Kathleen give us low, or however you guys want to mention it.
Okay, so for intracranial hypertension, the team is, first of all, every team needs a captain. Either a neurologist or a neuro-ophthalmologist should preferentially be the captain of the ship. So for the neurologist in practice, you want to work with either a neuro-ophthalmologist or an ophthalmologist, very important. You probably also need to have good relationships with neuroradiology as well as neurosurgery. And if you're thinking about a stent, then you're going to talk about interventional radiology. You may also have to call your colleagues in the bariatric team, whether the patient's going to have surgery or have just a good bariatric medical weight loss program, perhaps even an endocrinologist if it's somebody that you suspect has polycystic ovarian syndrome. So the team can actually get to be very large at some point. And then headache specialist if you're not a headache specialist, right?
So quite an entourage there.
Yeah.
Great. So let's tackle low pressure SIH.
So have the high index of suspicion in all the patients you see with headaches that aren't getting better. Work with the neuroradiologist to develop a protocol for making sure that you get the right MRI scan of the brain with gadolinium and that they're looking for a SIH situation and that they know how to do heavy T2 weighted spine imaging with fat saturation to look for a possible dural tear. And then more interventional neuroradiologists that will do a CT myelogram to look for the leak. And if your center can do digital subtraction myelography, that would be wonderful. And finally, which is not easy to find, is neurosurgeons that want to deal with this problem because it is not an easy problem to deal with. But if you can find one that is willing to work with you, it's wonderful.
I would just really emphasize that neuroradiology is the critical piece of managing and diagnosing SIH. You really need a neuroradiologist who's got a vested interest in it. For those who are in practice in the community or not in an academic medical center, the imaging that your patients get may not be read by a neuroradiologist. It may be read by a general radiologist. And so it is certainly possible that findings are missed because an experienced neuroradiologist is not reading the films.
Great. Any final thoughts?
Well, I'll just say pressure disorders are going to be in our clinics as neurologists all the time, and being prepared to take care of the headache part of this is incredibly important. Getting the right diagnosis is really important, and thinking about the diagnosis is really important. And for our IIH patients, I do think we have to really work on the weight loss first after we've made sure that they're not losing vision. And if you don't have a way to partner to look at the vision, you really have to have somebody helping you with the visual side of this because we don't want people to lose vision.
Yes, my parting shot is I'm so happy that we got to do this.
Yeah.
And to talk about these problems for all of our colleagues, around the world, basically. It's really been a pleasure and an honor. And for IIH, my diagnostic clinical pearl is follow the diagnostic criteria. We wrote them to keep you safe, keep you away from the attorney, and to make sure that we do the right things for our patients.
Well, that's a wrap up. Thank you both.
Thank you so much for having us.
Yeah, thanks very much.
Well, that about wraps it up for this session on high and low CSF pressures as part of our November headache series.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.